Blood cell egress. Special property of the maturing hematopoietic cell and of the venous sinus wall. The special property of maturing hematopoietic cell and venous sinus wall are important in migrating the blood cells from the bone marrow to the circulation. These cells must migrate between the reticular cells but through the endothelial cells to reach the circulation. So the cells, hematopoietic stem cells, these should go through the endothelial cells between the reticular cells, through the endothelial cells between the reticular cells to reach the circulation. As cell traffic across the sinus increases, the reticular cells contract, creating a less continuous layer over the abluminal sinus wall. Abluminal means away from the lumen. Abluminal means away from the lumen. That is the cell, whatever you are telling vessel wall, no, sinus wall, that is abluminal sinus wall. So whenever the traffic across the sinus increases, the reticular cells contract. Because they are contracting, there is a less continuous layer. When the reticular cell layer contracts, it creates a compartments between the reticular cell layer and the endothelial layer, where mature cells accumulate and can interact with sites on the sinus endothelial surface. The new blood cell interacts with the abluminal endothelial membrane by a receptor mediated process, forcing the abluminal membrane into contact with luminal endothelial membrane. The new blood cell interacts with the abluminal endothelial membrane, that is outside the lumen, outside surface. With that abluminal surface of the cell membrane, receptor mediated process, the hematopoietic cell will, the mature cells will contact or mediate, forcing the abluminal membrane into contact with luminal endothelial membrane. The two membranes fuse, and under pressure from the passing cell, they separate, creating a pore through which the hematopoietic cell enter the lumen of the sinus. See, the two membranes, whatever the abluminal and the luminal endothelial membrane, the two membranes fuse, and under pressure from passing cell, they separate, creating a pore through which the hematopoietic cell enters the lumen of the sinus. Let me explain you this with a very clear explanation. Okay, so see, there is endothelial cell, there is endothelial cell in the sinus vessel wall, sinus wall. Outside that vessel wall, there is hematopoietic stem cells. Whenever these mature cells start accumulating, this is sensed by reticular cells, that is fibroblast, and they contract and make space for the mature cells to go between the reticular cells. As they contract, as the fibroblast contract, there is more space available to go between the fibroblasts. When they pass between the fibroblasts, now the endothelial cell is there. Only single layer of endothelial cell is there, that to abluminal surface, that is vessel wall endothelial cell. Outside the vessel there is one surface, right? Inner surface is there, outer surface is there for the endothelial cells. In the outer surface of the endothelial cell, when it comes in the contact with a mature cell, the mature cell will tell the endothelial cell that I want to go in, let me in. So then what happens is, endothelial membranes, outside membrane, inside membrane, they fuse together, and the width of these endothelial cells, I mean the whatever the thickness we call, it's not actually thickness, but for understanding I am telling you the thickness of endothelial cell will shrink and becomes like a membrane. Both membranes will fuse, and because this becomes thin, now because of the pressure of the hematopoietic cell, it makes a hole and pierces through and through to the endothelial cell, and then it enters the circulation. These pores are only 2 to 3 micrometer in diameter. Thus, blood cells must have the ability to deform so that they can pass through the sinusoidal lining. Progressive increases in deformability and motility have been noted as granulocytes mature from the myeloblast to the segmented granulocyte stage, facilitating the movement of cells into the sinus lumen. Many soluble factors are important in regulating the release of blood cells from the bone marrow, including granulocyte colony stimulating factor, granulocyte monocyte colony stimulating factor, and a large number of chemokines. Some of these molecules are used clinically to increase the circulating granulocytes or release the hematopoietic stem cells into the circulation to obtain the granulocytes for transfusion of stem cells for transplantation. Now, this is about the blood cell egress. Coming to the extramedullary hematopoiesis, we have seen that hematopoiesis in the bone marrow is called as a medullary hematopoiesis. Extramedullary hematopoiesis denotes the blood cell production in the hematopoietic tissue other than the bone marrow. In certain hematologic disorders, when hyperplasia of marrow cannot meet the physiological blood needs of the tissue, extramedullary hematopoiesis can occur in the hematopoietic organs that were active in the fetus, principally the liver and spleen. Organomegaly frequently accompanies significant hematopoietic activity at these sites because liver and spleen will work harder. Medullary cavity or medullary hematopoiesis is decreased, extramedullary hematopoiesis increased. So that's why extramedullary hematopoietic sites are liver and spleen. These will enlarge. That's why hepatomegaly and splenomegaly we can see. Coming to the thymus. The thymus is a lymphopoietic organ, lymph producing organ, lymph cells, lymphoid cells. Located in the upper part of the anterior mediastinum, it is bilobular organ demarcated into an outer cortex and central medulla. The cortex is densely packed with small lymphocytes, that is thymocytes, cortical epithelial cells, and few macrophages. As we have discussed, macrophage is like a soldier where he will be outside only, no? So that's why in the cortex you can see the macrophages and lymphocytes, cortical epithelial cells also, that's like compound. This medulla is less cellular and contains more mature thymocytes mixed with medullary epithelial cells, dendritic cells, and macrophages. Here also macrophages are there. T lymphocyte, thymus, in the thymus, what happens is macrophages are everywhere. Outside also macrophages, that is cortex. Inside also macrophages, that is medullary cavity. How you can imagine this is that in the cortex there are immature cells, that is small lymphocytes, thymocytes. As you go in the medulla in a more secure environment, these mature thymocytes are there because they are protected in the deep of the thymus, depth of the thymus, because these are very important mature thymocytes. The primary purpose of the thymus is to serve as a compartment in which T lymphocyte mature. It's just a compartment. It's just a nourishing organ, thymus. Precursor T cells leave the bone marrow and enter the thymus through the arterioles in the cortex. As they travel through the cortex into the medulla, they interact with epithelial cells, dendritic cells, which provide signals to ensure that T cell can recognize foreign antigen but not self antigen. These dendritic cells are there, no? Dendritic cells, epithelial cells. They have done a lot of battles. They are like the supreme, kingmakers. Okay, these have fought many battles. Now, when this prince enter the castle, it's like the castle. The prince is that immature T cell. When he goes through the training, these dendritic cells, epithelial cells, with their knowledge, they will start telling the immature T cell, they will start training to recognize the self antigen, to recognize outside antigen. They start training these T cells as it goes from cortex to the medulla, which provides signal to ensure T cells can recognize foreign antigen but not self antigen. They also undergo rapid proliferation. Only about 3% of the cells generated in the thymus successfully exit the medulla as a mature T cells. Only 3%. The rest die by apoptosis. This is a very cruel, very brutal training. Only 3% will graduate out of this thymus as a mature T cells from the medulla. The rest die by apoptosis that are removed by the thymic macrophages. This is the function of macrophages. That's why so many macrophages are there. In cortex also macrophages are there. In medulla also macrophages are there. These medullary macrophages, what they will do, they will just clear off these whatever the dead 97% of the T cells. That's a lot of dead T cells. The thymus is responsible for supplying the T dependent areas of lymph nodes. The thymus is responsible for supplying the T-dependent areas of lymph nodes, spleen and other peripheral lymphoid tissue with immunocompetent T lymphocytes. They will supply the immunocompetent T lymphocytes, that is 3% of the T lymphocytes that coming off the medullary. They will go to the lymph nodes, they will go to the spleen and other peripheral lymphoid tissue. The thymus is a well-developed organ at the birth, continues to increase in size until puberty. After puberty, however, it begins to atrophy until old age. When it becomes barely recognizable, this atrophy may be driven by increased steroid levels beginning in puberty and decreased growth factors levels in adults. The atrophy is characterized by reduced expression of transcription factor FOXN1. Remember this, thymus is atrophied because there is reduced expression of transcription factor, that is FOXN1. So all these structure like cortex, medulla, dendritic cells and epithelial cells training the T cells, immature T cells and macrophages that are clearing of apoptotic cells, only 3% of the T cells that are going out of the medulla. All this architecture is based on only expression of FOXN1. If FOXN1 is absent, then all this structure will collapse. The atrophy is characterized by reduced expression of transcription factor FOXN1 required for the thymic epithelial cell differentiation. The atrophied thymus is still capable of producing some new T cells if the peripheral pool becomes depleted, as occurs after the lymphoid irradiation that accompanies bone marrow transplantation. Now coming to the spleen, we have studied about the thymus. Let's just revise thymus again. It is very exhausting, but just revise. Okay, there is one cortex, there is medulla. Cortex has macrophage as well as medulla. Why? Because macrophage have a lot of work here, because only mature T cells, 3% of the mature T cells will exit the medulla. Rest 97% of the T cells die in the medulla itself. So that's why a lot of work for the macrophages to clear. So that's why a lot of macrophages. And in the cortex, small lymphocytes are there like thymocytes, cortical epithelial cells and few macrophages. In medulla, there are thymocytes mixed with the medullary epithelial cells and dendritic cells and macrophages. Here in the medulla, the training of T lymphocytes to become mature will occur by the epithelial cells and dendritic cells. This all architecture is orchestrated by FOXN1. FOXN1, what it will do, it will it will help differentiating epithelial cells, thymus epithelial cells. If FOXN1 is not there, then thymus will go into atrophy. The spleen is located in the upper left quadrant of the abdomen beneath the diaphragm and to the left of the stomach. After several emergency splenectomies were performed without causing the permanent harm to the patients, it was recognized that the spleen was not essential to life. Spleen is just an optional organ. However, it does play a role in filtering the foreign substances, old erythrocytes, from the circulation. What they are telling is it's not essential for living, but it will make the quality of life better. How? Because one, it filters the foreign substances that coming from outside into the body, foreign substances. Second, it will clear off the old erythrocytes. Storage of platelets and immune defense. Immune also, storage of platelets also. Oh, platelets are stored in spleen. Nice. So we'll see the architecture of the spleen here. First, we'll read the description. Okay. First, we just take a glance here. What is this immature thymocyte? This is thymus, not spleen. Okay. Thymus, as we have discussed, Hassel corpuscles are collections of epithelial cells that may be involved in the development of certain T cell subsets, that is regulatory T cells in the thymus. This is subcapsular cortex, and then we have cortex here. This is capsule. These are macrophages, and then immature thymocytes here, cortical epithelial cells here, thymocyte precursors here. As we go inside, there is dendritic cells here, and then mature thymocytes. These are mature thymocytes. That's how they will look. Hazel's corpuscles. These mature thymocytes. If I zoom this, medullary epithelial cells. These are medullary epithelial cells. Okay, epithelial cells and dendritic cells. This yellow color is dendritic cell. Red color is medullary epithelial cells. These are required for training, so they are training here. You can see there is a mature T lymphocyte here. There is one epithelial cell training this, and there is dendritic cell, and there is T lymphocyte to which it is training. Now you can observe that there is epithelial cell here, and in the center and periphery there are a lot of mature T cells. So it's like mature T cell is kind of head of the department. Dendritic cell is just associate or assistant professor. So dendritic cell will teach, but at the end the whole batch is addressed by the HOD, that is mature medullary epithelial cells. So that's why you can see this is called as a Hassel corpuscle. HOD at the center and students are T lymphocytes. They are surrounding this HOD. There is a final meet going on here before these T lymphocytes graduate out of this school. That is only 3% passing rate. That's very less. Now coming to the spleen. Spleen architecture, we'll see. Enclosed by a capsule, of course, of connective tissue, the spleen contains the largest collection of largest lymphocytes as well as macrophages in the body. These cells, together with the reticular meshwork, are organized into 3 zones. This is very important: white pulp, red pulp, and marginal zone. white pulp, red pulp, and marginal zone. The white pulp, a visible grayish white zone, is composed of lymphocytes. That's why it is white zone and is located around a central artery. There is central artery. Artery means already there is redness is there. We don't need more redness. So peripherally, and there is a white pulp that is composed of lymphocytes. That's how you can remember. The area closest to the artery, which contains many T cells as well as macrophages and dendritic cells, is termed as a periarteriolar lymphatic sheath, pulse. Periarteriolar lymphatic sheath. What kind of lymphatics? T cells, macrophages, dendritic cells. We have discussed that there is a artery, surrounding that there is a white pulp. In this white pulp there are lymphocytes like T cells, macrophages, and dendritic cells. This only we will call it as a periarteriolar lymphatic sheath. Peripheral to this area are a B cells arranged into follicles, a sphere of B cells within the lymphatic tissue. Within the lymphatic tissue, a sphere of B cells, that is called as a B cells arranged in follicles. Activated B cells are found in the specialized follicular areas called as a germinal centers. These are activated, which appear as a lightly stained areas in the center of a lymphoid follicle. The germinal centers consist of mixture of B lymphocytes, follicular dendritic cells, and phagocytic macrophages. Everywhere you see in the lymphoid organ, these dendritic cells have to be there, macrophages have to be there. The only difference is B lymphocytes and T lymphocytes. We'll read again. Peripheral to the periarteriolar lymphatic sheath. That means there is arteriole in the center. Surrounding that there is T cells, macrophages, and dendritic cells. Surrounding this there is a peripheral to this area are a B cells arranged in follicles. Activated B cells are found in the specialized follicles. These are germinal centers. These are like VIP people. They won't sit with the normal people, so that's why these are in the germinal centers, which appear as lightly stained areas in the center of a lymphoid follicle. The germinal centers consist of mixture of B lymphocytes, follicular cells, follicular dendritic cells, and phagocytic macrophages. The immune response is initiated in the white pulp. The immune response is there, no? It is initiated in the white pulp itself. Why? Because it is called as a periarteriolar lymphatic sheath. For its name at least, the immune response have to be initiated there. That's how you can remember. But actually it is containing T lymphocytes. So that's why the T helper cells, cytotoxic T cells, these are T cells that are specialized in immunity, immune response. So that's why in the white pulp only where these T cells are there, their immune response is initiated. In some cases of a heightened immunological activity, the white pulp can increase to occupy half of the volume of the spleen. It is normally less than 20%. The periarterial lymphatic sheath, whatever is there, white pulp, it is less than 20% or equals to 20%. But in lot of immunologically needed activity, it can exceed 20% and become bigger. White pulp can become bigger. White pulp is surrounded by marginal zone, a reticular meshwork containing blood vessels, macrophages, specialized B cells. So this is called as a marginal zone. Germinal centers are those which are activated B cells. Okay, but these specialized B cells are there in the marginal zone. That is like a reticule, like a mesh of blood vessels as well as macrophages as well as specialized B cells. This zone lies at the junction of white pulp and red pulp, and is important in initiating the rapid immune responses to the blood-borne pathogens and performing functions similar to that of the red pulp. The red pulp contains sinuses and cords. The sinuses are dilated vascular spaces for venous blood. The pulps are red color is caused by the presence of large number of erythrocytes in the sinuses. The cords are composed of masses of reticular tissue and macrophages that lie between the sinuses. The cords of the red pulp provides zone for platelet storage and destruction of damaged blood cells. Cords are like mm, it's like a death zone. Okay, now coming to the blood flow of the spleen. Spleen is richly supplied with the blood. It receives 5% of total cardiac output, a blood volume of 300 ml per minute. Blood enters the spleen through the splenic artery, which branches into many central arteries. Vessels branches can terminate in the white pulp, red pulp, or marginal zone. Blood entering the spleen can follow either the rapid transit pathway, that is closed circulation, or slow transit pathway, that is open circulation. The rapid transit pathway is a relatively unobstructed route by which the blood enters the sinuses in the red pulp from the arteries and passes directly to the venous collecting system. In contrast, blood entering the slow transit pathway moves sluggishly through the circuitous route of macrophage lined cords before it gains access to the venous sinuses. Plasma in the cords freely enters the sinuses, but erythrocytes meet resistance at the sinus wall where they must squeeze through the tiny openings. This skimming of plasma from the blood cells sharply increases the hematocrit in the cords. Sluggish blood flow and continued erythrocyte metabolic activity in the cords result in the splenic environment that is hypoxic, acidic, and hypoglycemic. It is less in sugar, less in oxygen, less in pH. Hypoxia and hypoglycemia occur as erythrocytes utilize available oxygen, glucose, and metabolic byproducts create the acidic environment. So let's just quickly go through this diagram of spleen here, a schematic drawing of the splenic. See an explanation. We have seen the periarterial lymphatic sheath contains many T cells, macrophages, and dendritic cells. B cells are arranged in follicles. Activated B cells are in germinal center. Now this is the spleen. There is a trabecular artery here, central artery. Then this artery is dividing into many other branches here. Okay, this around the artery, surrounding this, there are white zones. You can see this, right? This is called as a white pulp. So that's how periarterial lymphatic sheath will come, T cell zone. This is marginal zone. In the marginal zone, there are follicles here. In the follicles, there is germinal center where activated B cells will be there. This is mantle layer. We call it as a mantle layer. The mantle layer is in between the germinal center and marginal zone. Marginal zone, germinal center, in between there is a mantle layer here. These are splenic sinuses, trabecular veins, red pulp cord, just very periphery to the all these white pulp and all. There is red pulp. This is capsule. Again, we can see germinal center here, marginal zone, trabecular artery, germinal center, again follicle. So this is the splenic structure. Coming to the function, blood that empties into the cords of the red pulp, or marginal zone takes the slow transit pathway because it is going very far. Red pulp, marginal zone, very far. So that's why it's slow transit pathway. That's how you can remember, which is very important to the splenic function, including the culling, pitting, and storing blood cells. Culling, pitting, and storing of blood cells. The discriminatory filtering and destruction of aged or damaged red cells by the spleen is termed as a culling. Culling means just, murdering of red cells. Aged red cells, they are murdered. That is culling. Cunningly murdering is called as culling. That's how you can remember. Cunning act of killing the aged RBCs is called as a culling. Cells entering the spleen through the slow transit pathway becomes concentrated in the hypoglycemic hypoxic cords of red pulp, a hazardous environment for aged or damaged erythrocytes. Slow passage through the macrophage rich route allows the phagocytic cells to remove these old or damaged, less deformable erythrocytes before or during their squeeze through the 3 micrometer pore to the venous sinuses. When they are going from the arterioles, when they are moving through this passage, okay, this cords, red pulp, marginal zone, the blood will become very sluggish, very slow movement. When the blood becomes very slow, macrophages will get more time to clear off these red cells. They will concentrately check that which cell is aged, which cell is not aged. Then they will process of culling will takes place with the RBCs. They will just clear off these aged RBCs out before it even enters the sinuses. When something that enters the sinus means it is a normal erythrocyte, it is not aged. Normal erythrocytes withstand this adverse environment and eventually re-enter the circulation into the sinus. Pitting refers to the spleen's ability to pluck out particles from the intact erythrocytes without destroying them. This is called as a pitting. They just pluck out the particles, they just take out the particles from the RBCs without damaging the RBCs. That is very intelligent. Blood cells coated with the antibody are susceptible to pitting by macrophages. Suppose one blood cell is there, it is coated by the antibody. It's very active, very aggressive blood cell that is susceptible to pitting by the macrophage. If pitting is taking place by the macrophages in the spleen, means that blood cell is coated with the antibody already, because macrophage is what? It just recognizes antibodies. It's just immune function, right? Clearing of phagocytosis. What is required? Some immune response is required, right? Antibody. So if macrophage is pitting something, it is taking off of RBC, that means that RBC is coated heavily by the antibodies. If antibody coating is not there, then pitting will not take place. The macrophage removes the antigen antibody complex and the attached membrane. Along with that, the pinched off cell membrane can reseal itself, but the cell cannot synthesize lipids and proteins for new membrane due to its lack of cellular organelles. Therefore, extensive pitting causes a reduced surface area to the volume ratio, resulting in the formation of spherocytes. Erythrocytes that have no area of a central pallor on stained blood smear. That is what spherocyte is. The presence of spherocytes on a blood film is evidence that the erythrocyte has undergone membrane assault in the spleen. How beautiful it is, right? See, from the central artery, there is two pathways, right? One is sluggish, open and sluggish. One is like fast movement. What do you call it as? Closed circulation. Rapid transit pathway, as well as another pathway is slow transit pathway, that is open circulation. In slow transit pathway, where the blood goes till the red pulp marginal zone, since it goes very far before entering the venous sinus, it has a hypoxic nature there. In that environment, there is hypoxia, there is hypoglycemia, there is acid acidic environment. In that, when these RBCs are traversing in the open circulation, uh, slow transit pathway, that's what it is, right? Slow transit pathway, yes, slow transit pathway. Cells entering through the spleen through the slow transit pathway, whenever they are entering through the slow transit pathway, there is a hypoxia, less oxygen, less glucose, and less pH. In that, these RBCs become very sluggish. So when they become very sluggish, they will move very slowly. In that, there is this macrophage. It will keep an eye on these all blood cells, RBCs, when they are moving. When it sees RBC, which is coated heavily in its cell membrane with antibodies, antigen complexes, it just recognizes that red cell, and along with the antigen and antibody complex, it just removes a part of membrane. So when it is just pitting off, just taking off all the antibody antigen complex, macrophage, when it is consuming, this RBC will not just rupture and go off. This RBC just covers that membrane and becomes from biconcave to it becomes like spherocyte, because there is less membrane but more volume. So that's why it becomes spherocyte. So whenever in the peripheral blood smear you see a spherocyte, a nice round spherocyte, that means the assault has been happened. When you see, it's like philosophically, when you see some beautiful minds, beautiful people, good souls, these are the people that have undergone a lot of assault. That's how you can correlate this philosophically. That's what pitting means. The white pulp and marginal zones of spleen are important lines of defense in the blood-borne infection. Red pulp is just checking, whereas white pulp and marginal zones of spleen are important lines of defense in the blood-borne infection because of their rich supply of lymphocytes, phagocytic cells, and the slow transit circulation through these areas. Blood-borne antigens. These blood-borne antigens are forced into close contact with macrophages, functioning as antigen presenting cells and lymphocytes, allowing for recognition of antigen as foreign and leading to phagocytosis. T and B cell activation and antibody formation. One more time, blood-borne antigens are forced into close contact with macrophages and lymphocytes, allowing for a recognition of antigen as a foreign and leading to the phagocytosis. T and B cell activation and antibody formation. The spleen's immunologic function is probably less important in the well-developed adult immune system than in still developing immune system of the child. Young children who undergo splenectomy may develop overwhelming, often fatal infections with encapsulated organisms such as Streptococcus pneumoniae, Haemophilus influenzae. This can also be a rare complication of splenectomy in adults. The loss of marginal zone can be especially important in this regard. because these marginal zone, how it is, this architecture, everything, there is this arteriole, surrounding that there is periarteriolar lymphoid sheath where there is T lymphocytes, and there are macrophages surrounding the artery, because these are immunologically active and they are checking for any antigen bacteria that are there in the circulation. Surrounding that there is a marginal zone where there are specialized B cells are there. These are like a second line of defense. After that there is this germinal center where these activated B cells are there, like very furious B cells. So the marginal zone and germinal center, between that there is something called as a mantle zone, and this is just white pulp. Then comes the red pulp. Red pulp we have discussed there in the slow transit, so slow pathway. So that's how it works. The red pulp cords of the spleen act as a reservoir for platelets. Red pulp is for reservoir of platelets, sequestering approximately 1/3 of the circulating platelet mass. Massive enlargement of the spleen can result in the pooling of 80 to 90% of the platelets here only, producing the peripheral blood thrombocytopenia. I was always wondering why in splenomegaly there is a platelet problem. Here is the answer. Because in the red pulp there is a lot of platelets, like majority of the platelets there only it is stored. Since there is a massive enlargement of splenomegaly, pooling of 80 to 90% of the platelets producing the peripheral blood thrombocytopenia. In spleen only all these platelets are there. In periphery there is no platelets. Removal of the spleen results in the transit thrombocytosis with a return to the normal platelet concentration in about 10 days. So this is opposite. If spleen is getting bigger, then platelets are staying there, and in periphery, peripheral blood smear, there is no platelets. In opposite to this, if you are removing the storage spleen, spleen only you are removing, then platelets, where they have to stay, they can't stay. Their home is being removed. That's why these platelets will be circulating in the peripheral circulation only. That's why thrombocytosis, the increased platelets. Now coming to the hypersplenism. Why there is a hypersplenism? In a number of conditions, the spleen can become enlarged, and through exaggeration of its normal activities of filtering and phagocytosing, cause anemia, leukopenia, thrombocytopenia, and combinations of cytopenias. In a number of conditions, the spleen can become enlarged, and through exaggeration of its normal activity of filtering and phagocytosis. Now, this spleen is like hyperspleen, like it is a Superman. Like it does all the activity in excess. Like it will store a lot of platelet, that was thrombocytopenia. It will remove a lot of bloods, that's why a lot of RBCs, that's why anemia. It also does leukopenia, so there is a pancytopenia, combinations of cytopenias. Uh, a diagnosis of hypersplenism is made when three conditions are met. Anemia should be there, leukopenia should be there, thrombocytopenia should be there in the peripheral smear. 1. Second is existence of cellular and hyperplastic bone marrow corresponding to the peripheral blood cytopenias. There should be cellular or a hyperplastic bone marrow. Third is that occurrence of the splenomegaly. So altogether, spleen should be big and there should be anemia, leukopenia and thrombocytopenia, all the penias. But all the penias are there, there is spleen is big, but there is a bone marrow, hyperplastic bone marrow corresponding to the peripheral blood cytopenias. The correction of cytopenias following splenectomy confirms the diagnosis. If spleen is removed, then cytopenias are improved, then confirmed that it is hypersplenism. Hypersplenism has been categorized into two types, primary and secondary. Primary hypersplenism is said to occur when no underlying disease can be identified. The spleen functions abnormally and causes the cytopenias. This type of hypersplenism is very rare. Secondary hypersplenism occurs in those cases in which an underlying disorder causes the splenic abnormalities. Secondary hypersplenism has many and varied causes. Hypersplenism can occur secondary to the compensatory hypertrophy of this organ. Hypersplenism can occur secondary to the compensatory hypertrophy of this organ. Inflammatory and infectious diseases are thought to cause the splenomegaly by an increase in the spleen's immune defense function. For example, an increase in the clearing of a particulate matter can lead to an increase in the number of macrophages. Hyperplasia of lymphoid cells can result from the prolonged infection. Several blood disorders can cause the splenomegaly. In these disorders, intrinsically abnormal blood cells or cells coated with antibody are removed from the circulation in a large number, that is a hereditary spherocytosis, immune thrombocytopenic purpura, infiltration of the spleen with the additional cells. Metabolic byproducts can also cause the hypersplenism. Such conditions include disorders in which the macrophages accumulate large quantity of undigestible substances. Some of these disorders, such as Gaucher's disease, where there is a hypersplenism, neoplasm, in which the malignant cells occupy much of the splenic volume, can cause splenomegaly if the tumor cells incapacitate the spleen. Peripheral blood will show evidence of the hyposplenism, similar to the findings after the splenectomy. Um, Congestive splenomegaly can occur following the liver cirrhosis with portal hypertension, congestive heart failure, when blood that does not flow easily through the liver is rerouted through the spleen. Now, fastly, we'll just cover the splenectomy. Splenectomy can relieve the effects of the splenism, hypersplenism. However, this procedure is not always advisable, especially when the spleen is performing a constructive role as a producing antibody or a filtering protozoa or bacteria. Splenectomy appears to be most beneficial in a patient with a hereditary or acquired condition in which the erythrocytes, platelets are undergoing increased destruction, such as hemolytic disorders or immune thrombocytopenia. All these conditions where erythrocytes are decreasing, platelets are decreasing, the peripherals, peripheral circulation, then it is assessed that if spleen is removed, this all will be come to normal, hemolytic and immune thrombocytopenia. So in that case, splenectomy is advised. The blood cells are still abnormal after splenectomy, but the major site of their destruction is removed. Blood cells are abnormal, but their destruction is removed, so that's why it is beneficial. Consequently, the cells have a more normal lifespan. Splenectomy results in characteristic erythrocyte abnormalities that experienced clinical laboratory professionals can note easily on a blood smear. Splenectomy results in characteristic erythrocyte abnormalities. Okay. After splenectomy, the erythrocyte often contain inclusions like Howell-Jolly bodies, Pappenheimer bodies. These are visible after splenectomy and abnormal shapes. The lifespan of healthy erythrocyte is not increased after splenectomy. Other organs, primarily the liver, assume the culling function, that is, cunningly killing these RBCs. Old RBCs are killed. That is performed by the liver. That's why the lifespan of healthy erythrocyte will not increase, because liver is taking care in absence of spleen. Blood flow through the liver also is slowed by passage through the sinusoids. which are lined with specialized macrophages called as the Kupffer cells. These macrophages can perform functions similar to those of phagocytes in the splenic cords, and marginal zone. Even when spleen is present, the liver, because of its larger blood flow, is responsible for removing most of the particulate matter of the blood. The liver, however, is not as effective as spleen in filtering the abnormal erythrocytes, probably because of the relatively rapid flow of the blood past hepatic macrophages. See, spleen will also remove the particulate matter from the blood, that is antigen antibody complex that we have told. There is pitting, spirocytes will form. All this will be done by spleen also, liver also. Liver Kupffer cells are there, which are specialized macrophages. So, but liver does not do it efficiently. Why? Why? Because there is a lot of blood flow, as well as there is not slow flow of the blood in the liver. So that's why macrophages, these Kupffer cells, will not get sufficient time to examine, whereas in the spleen the blood flow will be very slow. So that's why these macrophages will get time to examine these RBCs and just perform pitting. Acquired hyposplenism is a complication of a sickle cell anemia. The spleen's acidic, hypoxic, hypoglycemic environment leads to the sickling of the erythrocytes in the spleen. This leads to a blockage of the blood vessels, infarcts surrounding the tissue. The tissue damage is progressive and leads to a functional splenectomy. When there is sickling, there is blockage of vessels that will lead to the infarct of the spleen. Gradual infarction lead to the automatic splenectomy, functional splenectomy. Okay. Coming to the lymph nodes, the lymphatic system is composed of lymph nodes and lymphatic vessels that drain into the left and right lymphatic ducts. Lymph is formed as a filtrate of blood plasma that escapes into connective tissue. Lymph is formed as a filtrate of blood plasma that escapes into connective tissue. The lymphatic vessels originate as a lymphatic capillaries in the connective tissue spaces throughout the body, collect the lymph and carry it towards the lymphatic ducts near the neck, where the fluid re-enters the blood. The bean-shaped lymph nodes occur in the groups or chains along the larger lymphatic vessels. Fluid from the lymphatic vessels enters the lymph node through the afferent lymphatic vessels and exit through the efferent lymphatic vessels. Lymph nodes contain an outer cortex and inner medulla, same as spleen, same as thymus. Rather, the lymph node is more similar to the thymus in this way. Fibrous trabeculae extend inwards from the capsule to form irregular compartments within the cortex. The cortex contains B cell follicles surrounded by the T lymphocytes. First, B are there in the center, surrounded by T lymphocytes and macrophages. Similar to the spleen, some follicles contain areas of activated B cells known as a germinal centers. Here also activated B cells are there. A stimulated node can have many germinal centers, but a resting node contains follicles with small resting lymphocytes and macrophages. The medulla, which surrounds the efferent lymphatics, the medulla, which surrounds the efferent, that is going out lymphatics, consist of cords of B cells, plasma cells, and macrophages that lie between the sinusoids. Lymph nodes act as a filters to remove the foreign particles. Lymph nodes act as a filters to remove the foreign particles from the lymph by resident dendritic cells and macrophages. In addition, dendritic cells activated in the tissue can travel via lymphatic to the lymph nodes. Dendritic cells in turn stimulate T and B cells. These are like travelers. Dendritic cells activated in other tissues, like somewhere very far, they will enter the lymphatics, go to the lymph nodes, and they tell the lymph node T cells and B cells to get activated. So these are like messengers, dendritic cells. Stimulated B cells move from the germinal centers to the medulla, where they reside as a plasma cells and secrete antibodies. Thus, lymph nodes provide immune defense against the pathogens in virtually all tissues. In all tissues, these nodes are there, like all tissues, because all tissues need soldiers, right? These soldiers are in the barracks. These barracks are lymph nodes. These are spread across the body as a lymphatic network. Afferent will bring the these dendritic cells and lymph towards the lymph node. This filtering will takes place. If dendritic cells will come, they will activate B and T lymphocytes. These B specialized activated germinal center B cells will go to the medulla, and they will be secreting a lot of antibodies. Mucosa-associated lymphoid tissue, MALT. Collection of loosely organized aggregates of lymphocytes. Lymphocytes are there, but they are loosely aggregates found throughout the body. Before discussing the MALT, let's just see the lymph node structure. Okay, this is lymphatic capillary efferent, but this is afferent. So lymph will enter from here. Okay, lymph will enter from here. So this is sinus here. Surrounding that, sinus is there. This is capsule. Okay, the capsule will dip in some areas. Okay, cortical sinuses. This is cortex. These are the follicles here, small follicles. Okay, this is the germinal center that I am talking. When there is this follicle in the cortex, these are germinal center where activated B cells will reside. Interfollicular area, where these B cells are there, this is marginal zone, this is cortex. Okay, in this cortex there are T lymphocytes. Interfollicular area is where their T lymphocytes reside, and by these arteries and veins, these will be taken, and there is a medullary sinus here. Medulla, there is plasma cells in the medulla. That is the specialty. So vein will take all the things, and arteries will bring the things, and then arteries and then veins are there. From here, plasma cells, they will go to the lymphatic capillary efferent network. Now coming to the MALT. Collections of loosely organized aggregates of the lymphocytes found throughout the body in association with the mucosal surface are mucosa-associated lymphoid tissue. In the mucosa, there are loosely organized lymphocytes. That's why it is called as lymphoid tissue, mucosa-associated lymphoid tissue. Its basic organization is similar to that of lymph nodes, in that T and B cell rich areas can be identified but are not as clearly demarcated as in the lymph nodes. In the lymph nodes, how it was in the germinal center, there are activated B cells, and that there is a marginal zone is there. Peripheral to the marginal zone, there are T lymphocytes, then macrophages. This sharp demarcation was there in the lymph node, but here in the MALT, there are B cells, T cells, everything is mixed, like it's like loosely organized. Okay, you cannot clearly make out which is T cell area, which is B cell area. So that's the specialty of this. The medulla is not present as a separate structure, and no fibrous capsule can be identified. In the intestine, some of these aggregates are also known as Peyer's patches. Tonsils, appendix, also are a part of MALT. Its function is to trap the antigens that are crossing the mucosal surface and initiate the immune response rapidly. They will just identify the antigen harmful to the body and they will activate the immune system. So that's their activity. So that's why uh, in the mucosa, where there is a first line of defense, like suppose tonsils, if you take, these are MALT. They are like loosely arranged. B cells, T cells, everything will be there in the like haphazard manner. These will quickly, without discrimination, like how B cell was organized, how T cells were organized in a lymph node, there was some organized work. But here, this is like barbaric, like whatever comes to hand, just beat it. So that way it is loosely organized. Lymphadenopathy. Lymph nodes can become enlarged by expansion of the tissue within the node due to the inflammation, prolonged immune response to the infectious agent, or a malignant transformation of the lymphocytes or macrophages. Alternatively, lymph node enlargement can occur because of the metastatic tumor that originate extranodally. So that's about all the things. Like we have discussed about lymph nodes, we have discussed about spleen, we have discussed about thymus and its blood supply, we have discussed about blood cells, extramedullary hematopoiesis. All these are extramedullary hematopoiesis, like thymus, spleen, and then lymph nodes. So that's it.